All right. Well, thank you everyone for joining. We apologize for the delay in getting started, but we are all here now, so we'll just jump right in. Um, I am Michelle Kuba. I'm the Assistant Dean of Operations here at the school, and I'll be moderating the session today. So Dr. Alison Abraham will be presenting, and then there'll be some time at the end for questions. So please enter any questions that you have into the Q&A, and I'll be happy to read them. So with that being said, I'm excited to introduce Alison Abraham. Dr. Abraham is an associate professor in the departments of epidemiology and ophthalmology, the co-director of the epidemiology graduate programs, and the vice chair of education for the Department of Epidemiology. She's an epidemiologist, biostatistician, and biomedical engineer with 15 years of experience working in data coordinating centers of large multi-site observational cohort studies. Dr. Abraham has a deep interest in pedagogy and curriculum development. She's a founding member of the International Consortium on Teaching Epidemiology and an organizer of the international meetings on teaching epidemiology held in Zurich, Switzerland since 2018. She has published on competency development for the field of epidemiology and presented at national conferences on teaching methods. Her current research is in aging and sensory loss, and she's the PI of the Eye Determinants of Cognition study and the HIV vision study, studies of vision loss and retinal biomarkers. Her methodology foci are data quality improvement, measurement error, and the handling of missing data. She also applies her background in biomedical engineering to studies of diagnostic imaging. She has her BS from University of California, San Diego, her MS from California State University, and her MHS and PhD from Johns Hopkins Bloomberg School of Public Health. So I'll go ahead and hand it over to you.
Thanks so much, Michelle, for that very gracious introduction. It's always a little embarrassing to hear those. Good afternoon, everyone. Thank you so much for joining me to talk about public health education. And I'm definitely going to try to leave enough time for us to have a nice discussion after the talk. I wish we were all in a room together. It would make discussion a little more warm and friendly, but we will work with what we have. So I think all of us would agree that public health education is really critically important in a world where, we're facing declines in life expectancy. We've just faced down a pandemic, and where I think public health is being called on more and more to solve the complex health challenges that we face and will continue to face in the future. So I'm going to cover three topics today. The first is a vision for how our school curriculum for all of our programs might shift to, hopefully better train our students for the realities of solving today's complex problems. And the second is, I'm going to call it a call to arms for us to sort of rethink our educational mission and what communities we serve. And then finally, I'd like to start a discussion on how we can do potentially a better job with student well-being to make sure that we're not only bringing students into our programs, but also we're keeping them there through graduation. Okay, so when you read the news or really look at any health literature on sort of emerging health topics, it's pretty clear that there are a number of trends that will, deeply affect public health and the problems that we face. The first one is obvious. You see it everywhere. The population is aging. In fact, the U.S. Census Bureau projects that in 2034, adults age 65 and over are expected to outnumber children under 18, which is, sort of startling. And this trend is really seen on the global stage. The world's older than 60 population will surpass those that are younger than 14 by 2050. So, we're clearly going to have to face a shift in demographics that comes with a shift in sort of the disease burdens that we're seeing. A second challenge are intergroup health disparities, which are also on the rise, both here in the US and globally. And obviously the reasons for these growing disparities are complex, But at the same time, they might be sort of simple in the sense that the distribution of those disparities where you see sort of the most health burden also really echoes where we see the least health expenditures and the poorest access to care. Another challenge is going to be just the amount of data that we're facing. It is exploding, whether you're talking about high dimensional biomarker data or huge electronic health record databases, which opens the door obviously to opportunity and discovery, but at the same time, it risks our evidence base becoming sort of a wild west of unreliable results with very small p-values. Another challenge is globalization, which means to some extent, there's no such thing as a local health problem. Local health problems can quickly become global health emergencies, as we saw with COVID-19. And finally, climate change is just the huge elephant in the room that's going to layer on top of all of our current health problems, adding complexity to the solutions. I'm sure we could all think of several other fast-moving challenges coming at us. But I also want to note, sort of make a positive spin on this. These challenges are also opportunities to innovate and improve. So, the burning question for us today is, are we prepared for all of this? Do we graduate a public health workforce that has the skills to meet these challenges? So in the maybe I would call overly critical and certainly depressing report, Health Professionals for a New Century, Frank and colleagues argue absolutely no, we are not prepared for this. And their critique is that there is a mismatch of our competencies to the priorities and real challenges that public health professionals face because they don't have the right skills to keep pace with what is fast-moving changes in technology, explosive growth in knowledge, and often dysfunctional and inequitable healthcare systems. And I don't know if you can see my cursor, but I'm showing you this slightly lackluster figure that they put in their report that just tries to illustrate sort of all of those pressures being put on our public health workforce that we have not adequately trained them to handle. So Frank points to super specialization and professional silos as at least one problem. And I want to emphasize that's in terms of, our educational curriculum. And it turns out that theme is sort of echoed across a number of reports regarding our public health education. And certainly it's echoed in the NIH roadmap that was published in 2003. The roadmap urges us to move beyond the confines of our own discipline to focus more on team science. Why? Because complex problems cannot be solved within a single discipline. They really require, facile thinkers who can work across disciplines and partner. Solutions, will have to be transdisciplinary, system-wide, and probably, at multiple levels, at the individual level, the community level, et cetera. And, it's true, many of the problems that public health must tackle are, no longer, and maybe really they never were, sort of isolated discipline-specific problems. So our education, of course, needs to move beyond the individual disciplinary perspective to an integrated interdisciplinary approach. And that means curriculum must live sort of across departments. So public health graduates are aware of, conversant in, and really, adept at the breadth of expertise that constitutes public health. And I just want to emphasize this doesn't mean having a student take all of the classes in each department. Rather, what this means, an integrated approach, is that these classes are taught with a cooperation of faculty across departments so that perspectives are given across disciplines and integrated into the material. So it really is sort of a different way of thinking about curriculum. Often programs call this a common core. So I think we also have to think beyond our areas of public health science to tools that could best serve our graduates in their actual jobs. And these skills or competencies may be sort of far outside the usual realm of traditional public health curricula, but really reflect the realities of what is asked of our graduates when they enter the workforce. So what kind of skills do employers desire along with public health training? Well, I'll give you a couple of sources for sort of what I know about what employers want. This is I'm showing you a quote and then some takeaway points from a 2020 American College of Epidemiology roundtable that we did, where we brought employers together and just talked about the skills of the workforce and what employers saw as sort of the gaps. Some of the skills that were mentioned from that roundtable include community outreach skills, communication skills, and soft skills. Employers had a common lament, I think, that we heard, and that is, hey, you're doing a great job training students to code in a statistical language or calculate an odds ratio, but you're not doing such a good job training them to do the practical day-to-day needs of a job in public health. And here's a more recent example. This is from actually our own Department of Epidemiology External Advisory Committee report. This committee was convened as part of the CEF reaccreditation. CEF had made the recommendation that every department should have an external advisory committee, which was really a good recommendation. So this committee consists of employers that employ our students, and the goal is for them to give guidance and recommendations around our curriculum and identify the gaps and skills. And this is the report that I'm showing, just a little brief snippet of it from sort of the last year of discussions with this committee. So this is going to the department to just say what the recommendations are from that committee. And you'll notice some overlaps with the ACE roundtable, but also a couple new things come out. And those are budget management, public health administration and program management, leadership skills, and familiarity with the principles of EDI. So discussions really with both of these groups of employers and additional reports that I've reviewed as part of sitting on that committee as the department representative emphasize this idea of soft skills is sort of a repeating theme. And it's one of these fuzzy ideas that, I admit I wasn't exactly sure I could define, so I looked it up. And according to Forbes, which, clearly is the source on what soft skills are, soft skills revolve around being able to be effective in interacting with others in a professional setting. And the list of soft skills that Forbes gives you are communication, teamwork, creativity, adaptability, problem solving, work ethic, critical thinking, and conflict management. So, that's a great list. I think none of us could argue that wouldn't be a great set of skills to convey to our students and for ourselves as well. But, that's a lot to tackle, particularly since a lot of these things we really don't know how to teach. However, when you review the literature regarding public health education and education reform, a couple of these things do come up quite a bit. And those are critical thinking, communication, and knowledge mobilization, which is sort of, I think, a fancy term meaning that students can look at varying sources of information and they can consolidate all that information into some plan or idea to make improvement. So communication, as you saw, is sort of a repeating theme. I think we really know how to teach that, but I also think critical thinking and knowledge mobilization are things that we can definitely teach. So those of you who spend time in the classroom are probably familiar with Bloom's taxonomy, which was developed to describe learning objectives for students. And I think it really provides a framework for us in our classes to to think about how we move students up this ladder from, remembering or just understanding material to analyzing material, evaluating material, and then taking what they know and transforming it in order to create a new idea. And you can see those are sort of the levels of learning objectives. And I think getting to the top is all about teaching them to, mobilize knowledge and think critically. So to better prepare our students, just to sort of recap, we should be probably teaching in a more cross-disciplinary way, because that really reflects the realities of modern public health problems. And we need to think pragmatically about the real world skills that graduates need to function effectively in the workplace, and really thread those skills through the coursework. I think those are sort of some takeaways that I've gotten from the literature, and they make a lot of sense. But what else? So Gebbie et al. In a report titled "Who Will Keep the Public Healthy?" urged graduate programs to emphasize and educate from a perspective of an ecological approach to solving health problems. So this is certainly a viewpoint that has been championed by Nancy Krieger. She's a well-known social epidemiologist, and she has been hammering this point for at least 30 years, if not more. In her article from 1994 entitled "Epidemiology and the Web of Causation, Has Anyone Seen the Spider?" And I think as we talk further, you'll figure out what that spider is in her analogy here. She calls our current theory underpinning our health research as biological individualism. And that name sort of speaks to the focus of that theory, which is that health outcomes are really the product of sort of biological determinants of disease. And that perspective really sees populations as simply the sum of individuals. In contrast, an ecological approach or an eco-social model for health focuses on social drivers and system, community, or societal factors. So this draws directly from a famous paper by Jeffrey Rose, Sick Individuals, Sick Populations. And I make my students read this, and I read it every year because it really drives home the point that causes of individual cases of disease are not necessarily the same as drivers of incidence rates in populations. And I think as a School of Public Health, population health, we need to remember that. So what would such a framework for training public health students look like? Well, here is an example. This is an eco-social model applied by CDC to the problem of violence prevention. The model really implicitly orients us around the complex interplay between the individual, relationships, community, and society. And so looking at those factors, and it also sort of makes clear with these overlapping bubbles that factors in any one level influence factors in another level and vice versa. So that leads us to sort of the obvious conclusion that any solution to a problem, a health problem, has to really act across multiple levels to be successful because these factors are so intertwined. And I think such an underlying framework for our curriculum will really drive our training towards skills to partner across sort of all levels, in a system. It would sort of point our students towards more hierarchical data structures and hierarchical thinking, and also towards systems thinking. So just another example, whole person care is really the idea of applying an eco-social model to healthcare practice. This figure is from the Whole Healthcare Initiative. And I think it really drives home this idea that for healthcare practitioners, healthcare only contributes, by their estimation, about 20% to the variability in healthcare outcomes. The other 80% is from social, behavioral, and environmental drivers. So what this is saying to clinicians is if, you focus only on the things that you can control in the clinic, you're really missing the boat on the majority of what really affects health outcomes. So it's driving clinicians towards considering things, beyond sort of direct medical care. And for us, it's the same thing. If we focus only on biological determinants of disease, we are really missing the boat on what are probably the most important drivers, which are social and environmental, and those things, of course, also drive behavior. Okay, so I'm going to recap again. So we've added onto a cross-disciplinary approach to training and pragmatic skill training, a shift in our framework for thinking about drivers of health outcomes. So that's a really good start. What next? The Healthy America Practitioners for 2005 report advocated for training students in real-world community settings where they are exposed to and learn to work with a mix of professionals around a current public health challenge. So what's the underlying skill here? It's the skill to be able to work in teams and to find the right partners. As we've noted before, complex problems will require many people working across disciplines together for solutions. So learning how to function well in a team is clearly an important skill. And I think to some extent, we are already doing this. Though like everything, of course, we can always be better. But I think, we are generally a collaborative field and we partner often. But the partners that we gravitate towards tend to be other professionals, particularly other professionals across disciplines in public health. So I would sort of advocate to changing, this recommendation just a little bit to really a focus on partnering with the community. So community engagement can be incredibly important for all sorts of reasons. It one brings, I think, key insights to the table that we don't have. Community representatives have those insights. It fosters trust, and that is, of course, obviously a good thing. It can also empower the community to advocate for their own health. This is a discussion I just recently had with a colleague. So, that is very powerful. If we could sort of make the community their own advocates around public health, our job would get significantly easier. But critically, and the reason why incorporating it in a training program makes a lot of sense, is that community engagement may be the key factor actually in effectiveness of an intervention. So for those of you who were able to attend Alfredo Moravia's talk last week, you will absolutely recognize this example, which I shamelessly stole from him. So you may all recall Michael Bloomberg's ban on large sodas in New York City that happened maybe a decade ago or so. And it was a really interesting test case because, at the time, nearly 6 in 10 New York City residents were overweight or obese. So there was, clearly a public health problem. There was also at the time clear science, that science, of course, continues to grow, that overconsumption of sugar was a contributor to poor health outcomes. So, you have a burden, you have clear science that, there's a potential solution to this problem. And yet that ban ultimately failed. So why did it fail? Well, that was a very top-down, heavy-handed approach to intervention. And that meant that it was pretty easy for the beverage industry to convince the community that this was an infringement of their personal freedom, as opposed to a public health intervention intended to protect them from, those same predatory companies. So, why did the Bloomberg administration, or why didn't they reach out to the communities? I don't know. Maybe they did. Maybe no one had effective training in how to do it, or maybe they didn't see it as an important need until it was too late. Okay, so one more recap. So we have a vision for cross-disciplinary training that incorporates pragmatic skills for the workplace. It's based in an eco-social framework with opportunities to learn how to engage with the community. So, I think that is a lovely vision for sort of modernizing curriculum, but I want to add one final set of skills that's really endorsed by nearly every report on public health training going back to the Welsh Rose Report published in 1915. We need to train students to be leaders, and this is what Frank et al. Call enlightened change agents. Most of us do not get leadership training until, either we're thrown into a leadership role, in which case it's not really training, it's sort of a sink or swim situation, or we reach the faculty ranks and we get nominated for a leadership course. But through all the critical evaluations of public health education, that I have read, sort of repeatedly emphasize that leadership training should be an integral part of public health training. So what do these skills even look like? I think they're sort of fuzzy, like soft skills. But as I was reading through the literature, my eye caught on what is now, I think, my favorite definition of leadership. And this came from a report about the revitalization or change of the Columbia University Mailman School of Public Health MPH program. So they went about this reform process and wrote some very nice articles sort of about the motivation and the implementation of that. And in the article about the motivation, it was first authored by Linda Freed, who is the current dean of the Columbia University Mailman School of Public Health. And she's been in that role since 2008. So she was at the helm while they were going through this process of reforming their educational curriculum. And the way that she and her co-authors defined leadership was leadership is the ability to inspire and motivate with vision, to communicate effectively, to work successfully in teams, to organize, to listen, to realize personal limits and biases, to find consensus, and to bring the best work forward from all constituents, understanding each disciplinary contribution to solve a complex problem. And I love that. It has a lot of elements to it. And, when you unpack each of those phrases, that's a lot of skills and sounds a little bit intimidating for trying to incorporate this into curriculum. So, the question we're all probably wondering is, can these skills be taught? And the obvious answer really is absolutely. And I say that because management programs from schools of business have been teaching leadership for ages to students of business and management. So, there's no wheel to create here. That wheel already exists if we sort of reach out to management programs and figure out how they do it. What we have to do is decide that leadership skills are a priority, and then just adopt those, well-established tools for training leaders and provide leadership training, I think, throughout a student's program is really an integrated concept. Okay, so I'm going to now turn the page on what public health curriculum could look like to maybe better face our emerging challenges and just talk about how we could actually get there. How can we achieve some new vision, whether it's this one or some other version. So I'll first just say that, while it's sometimes really thrilling to be at the forefront of a revolution, I think there's a lot to be said about being able to learn from the experience of others. I often like jumping off high cliffs into the water, but I always make sure I'm second or third. So, the first thing that I think we can do is to look at the evidence base. So many programs have done this. For example, Columbia instituted curricular reform, as I've already hinted to, to their MPH program in the fall of 2012, using the model here with the blue columns and the white boxes. And you can sort of see the structure of how they rethought their curriculum. And you'll notice it really does echo a lot of the things that we've discussed. And right over on this side, what you'll see is some data, and I'm definitely not expecting you to be able to read that. I think it's a little too tiny. The point in showing this graphic is only to say that they did collect data. So this is from semi-early on in the implementation, so the data weren't maybe that robust, but by now they have a number of years of outcomes showing how this new curriculum has performed on various metrics. And so, those data we can use. I'm sure that they would be happy to help guide us through a process of curricular reform and tell us what they've learned. Here's another example. In 2015, the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill developed an interdisciplinary 4-course sequence in applied implementation science as part of a Master's of Public Health degree. They thought that, this was really a bucket of skills that would be very important for students, really looking at sort of the practical skills involved in implementation science. And I think that implementation science really sort of does encompass a lot of the skills that we've talked about in many ways. So it's sort of maybe another umbrella for thinking about a lot of those skills. So this is another direction that does incorporate, a lot of aspects of sort of thoughts on modernizing curriculum. And they have also, you'll notice here, collected data on outcomes, as any good school of public health would do. Again, when they wrote this, it was pretty new in the process, but they've now had some time to really evaluate how, teaching implementation science has improved their students' ability to sort of really be effective in the workforce. And then a last example, one of the earliest adopters of public health education reform was actually the University of Alabama at Birmingham School of Public Health, which designed and instituted a fully integrated public health core curriculum in the fall of 2001. And again, those words there, core curriculum and integrated, means that they, attempted to do this cross-disciplinary approach to education. I didn't see anywhere in the article that they had collected data, but I'm sure that they have. So those are just 3 examples of programs that, we could reach out to and look to inform any changes in our own curriculum. Okay, so that's sort of the first thing, is let's just use the evidence base and the models that are already out there to do, some informing of where we might want to go. The second thing is, really under the heading of practice what you preach. So you have to have, I think, community buy-in. Large changes in the way we educate our students, that require not only cooperation across departments, but also integration of really entirely foreign, at least to us, skill sets, will definitely require all of us to be on board and really excited about those changes. So Columbia University, for example, here describes, their extensive process that led to the final MPH curriculum, which included, you'll note, 170 faculty members, students, and staff, and it was a process that lasted 2 years. So, this is a message. This process really has to be inclusive, and it has to be measured in pace to make sure everyone feels that they had a voice and that they are part of the effort. And I'm just going to give one other example. This isn't about curriculum reform, but this was a process I was involved in. A small group of us set about to redefine the competencies for academic epidemiology. So the bucket of skills that we thought that, everybody who walks out of our programs needs to have at, some level of proficiency. And, we also spent a lot of time thinking about what the process was going to be to do this. And we ended up using an iterative process that sort of brought in ever expanding groups of partners to build a consensus around the final set of competencies. So at the very final stage of that process, we had involved 173 participants from 19 countries. And I think, through this process, contributors really sort of coalesce together. In fact, we ended up forming a group that continues to meet to this day called the International Consortium on Teaching Epidemiology. And I think that's really a testament to how the process led to buy-in and a feeling of being part of an effort. And that, that has continued into now sharing of resources, talking about how we can improve teaching. So, it takes a while and it takes a lot of people, but there's a lot of value that comes out of that. Okay, so I think the third thing we will need for implementation is to really define what that process is going to be. How are we going to come up with a new curriculum and how are we going to implement it? And all of that needs to be really transparent. So as you saw, Columbia's process was published, and that's certainly something that could be adopted, or any of these other institutions that have implemented curriculum reform. We could certainly look to those models and adopt them. Another idea is we could center the process around some particular framework, and I'm just presenting one framework, which is called user-centered design. And this is actually, it obviously comes out of technology development, but it's been used in implementation science. The idea underlying user-centered design is that you put the users at the center of the design process to create, whatever your deliverable is, the product or the service, in our case, new curriculum. And that is centered in a way that it then, strives to meet the needs and the expectations of those users. That is the sole focus. So as you can see, from this figure, there's a lot of elements to this process. It definitely has to center around information that comes from the users on their behaviors, needs, and motivations. And you can imagine ways that we sort of get that information. There's a piloting phase, and you have to then have evaluations of how those pilots do, and then you have to iterate. So the question from this approach is really, who are the users? The obvious answer is the students, but when you think about it a second time, maybe the answer is employers, or maybe it's the community. Whatever the user base is, this process really centers around those needs and expectations. And so I think the last step is really for us to go into this recognizing that the world is always changing. And there are likely health problems around the corner that we haven't yet even thought of, but may require, skills and knowledge that are sort of different than whatever we put into place. We cannot perfectly see the future and what the challenges are going to be. From a report on implementing the Institute of Medicine's recommended curriculum content in schools of public health, Shortell et al. Advised that we need a flexible approach to incorporating advances in public health knowledge. So effectively, this means we have to make sure that we have obviously a solid a priori process for evaluation of the program, looking at both sort of short and long-term successes, however we define that. And we have to not let ourselves stagnate. We have to then use that evaluation process, which would be ongoing, to adjust the curriculum as public health context and needs change. So, this would not be sort of a one and done thing, but I think if we're smart, we would sort of continue to tweak as, needs and challenges change. All right, so I'm going to turn the page here a little bit. We've talked about what we envision for innovative curriculum that hopefully can better meet challenges of today. And now I'd like to talk a little bit about the population that we serve. Who are we educating? And I think, even with curricular changes, we may not meet the needs to educate the public health workforce. And what do I mean by that? So we know that there's sort of a well-established gap in the number of public health professionals compared to the need. An analysis from the de Beaumont Foundation and the Public Health National Center for Innovations found that for our nation's minimum public health requirements to be met, we need an 80% increase in the people hired into the field. So this means that we have to churn out, double the number of graduates to start meeting that need. And at the same time, we have a raging epidemic of mis and disinformation, which means those public health professionals that we have a much harder time promoting the interventions and practices that promote health. And I'm going to stick a little pin in this idea and sort of go back a little bit towards the filling the gap. But you'll see how this misinformation and disinformation sort of becomes an important point. So, we want to expand enrollment, both because we want to meet this glaring gap in the public health workforce, but also because expanding enrollment is good for the health and sustainability of our school. But we've really traditionally focused on the conventional student population, which is really, young adults getting trained typically for their first career. So instead, what if we sort of thought about expanding our educational mission to be far more inclusive in who we aim to educate? For example, aging adults who have finished their first career but still have a lot to contribute. And what if we sort of think about repackaging public health education to be more accessible for those potential student populations, like the general public, like current professionals? So I see this reframing of the public health education mission as an opportunity to accomplish a number of goals. So first goal, expanding access to public health education, which is definitely a good thing. Two, reaching out to sort of new non-traditional constituencies, which would really allow us to walk the walk of diversity and inclusion with our recruitment efforts. And again, this is defining diversity, very broadly along a number of axes. It will also allow us to ramp up training of these diverse students to restaff our public health departments. We have more students coming in because we have more options for different potential student constituencies. And so, that's going to hopefully lead to more trained individuals at varying levels of training. Another goal I think we have is to build bridges with the community. So this would definitely do that by, offering to be a resource for public health information and training to the public. That will lead to hopefully trust and an increase in health literacy. And all that, I think, could help us fight the harms of disinformation. So that sort of goes back to the previous slide. I think this is a mechanism for helping us fight all the disinformation and misinformation that's coming down the pike. And finally, I think it could really help revitalize our school because it would bring in a lot of diverse perspectives and talents. And that can only be a good thing for sort of the energy of the school. Okay, so, how can we do this? How can we think about public health education, how it should be delivered, what it should do? I think what we need to do is think less in terms of degrees. Obviously, that will still be sort of our bread and butter, but adding to that the ideas of upskilling or micro-credentialing. And so, this would create sort of new kinds of learning opportunities to bring knowledge and expertise that's currently limited to graduate students to these other constituencies. And I just want to show you a couple models that we could look at. I'm sure these are not the only models out there. So here in Colorado, there's the mini med school. So this is really aimed at a general audience to increase health literacy. And I've actually joined a number of these lectures, and they're really good. So, again, bringing information to the community. The Think Like a Scientist program is run by Amy Bernard in the School of Medicine. She's in the Department of Immunology, and she goes into high schools to do science education. So I wasn't aware until she told me that many schools, when they have low scores for reading and math, drop their science programs in order to emphasize reading and math. And that's just a tragedy, because that means that, these young individuals are getting, no science education. And again, that's going to then have downstream consequences in terms of sort of the knowledge of the population, the general population. The ORS program, so this is Older Adult Research Specialist Training Program. This is also out of the School of Medicine, out of the Multidisciplinary Center for Aging, and they train adults to be involved in research. So, older adults coming in and helping out with the research mission. And now from Columbia University, there's the SHARP program. This is like a boot camp experience aimed at working non-health professionals. So, a very concentrated experience that provides some health and research training for them. And then there's also an accelerated MPH that they offer, which is a one-year program also geared at professionals who want to add, a full public health credential to their resume, but they don't necessarily have 2 years of time to get the traditional MPH degree. So I think, we have a lot to learn from these kind of models in terms of thinking innovatively about how we can repackage really what we already do to train, new kinds of students and meet the needs of a much broader group, subset of the population. Okay, I am apparently not leaving as much time as I thought, because we got started a little bit late, but I just have a few more slides. So finally, I'm going to just switch gears one last time to touch on the topic of student well-being. We work really hard to get students in the door, and we certainly don't want to see them fall back out. But, maybe even more importantly, as a School of Public Health, I think we have a vested interest in understanding and meeting the mental health and life challenges of our students. It's been, well documented that students report high levels of stress, and we know that emotional stress is one of the reasons that students disengage and drop out. Also, because of trends in cost of living and the cost of education, students are increasingly experiencing food insecurity and housing instability, which clearly impacts their educational engagement and, certainly diminishes their quality of life. It's really hard to focus on your degree program when you are experiencing housing instability or when you are experiencing hunger. So I think the school and campus have worked really hard to build services that can assist struggling students. There's crisis support through the student crisis response teams. There's the care teams that can provide support for issues like food insecurity. There are mental health services, a health center to make sure that students have access to care. There is a help hotline if a student is feeling unsafe. These services are wonderful, but they only work if students activate to connect to them or faculty become aware of issues and ask for help on behalf of the student. So the concern is that we may be missing students who, are sort of suffering alone. So, I think we need much better surveillance for student well-being. And the good news is, we're a school of public health, so we have a lot of expertise in surveillance. I am not an expert in surveillance, but I just want to bring sort of one idea to the forefront. This is an article in the Washington Post that I ran across about how we could harness technology to surveil our students around their well-being. EdSites is a company that uses AI chatbots and customized knowledge about the university and its services to interact with students through text. So, we've all seen these things. We get them all the time from various vendors or our healthcare providers. So this is, harnessing a well-used at this point technology, but it's sort of really targeting it towards checking on the well-being and needs of students. So these bots can be trained with maps for the campus to give directions. They can be trained on, class registration processes or, any academic process that they may not be able to figure out. So, students can get all the information they need, but it can also ping students on security and mental health issues and then refer those immediately to care teams on campus. So, sort of more immediate awareness of problems, hopefully before they become crises, and, immediate engagement with, humans who can help. And I just want to say I've not invested any money in EdSites yet. So this is not a promo. Okay, so we have a couple minutes left. I'm sorry I didn't leave more time. I just want to have everybody sort of walk away with some food for thought. So I'm just going to sort of give some takeaways. So first, I think that we can train better. It's clear that we have skill gaps, and it's also clear that there is sort of a robust literature and a lot of early pioneers in public health curricular reform to guide, a potentially bold path for better training. Second, we can rethink who our students should be and what public health education should look like to serve a broader public health education mission. Can we be a better resource to the community? Can we build trust while educating the masses in public health? And lastly, we want our students to have a fulfilling educational journey. We don't want them to struggle with the mental health and stress-related health outcomes, that many of us actually study. We don't want that happening sort of right under our noses. So can we do a better job monitoring student well-being to make sure that, our wonderful services reach them before, there's a crisis and it's too late? And I'm going to stop there and leave this slide up just as food for thought. Michelle, do we have a couple minutes for questions?
We do have a couple of minutes for questions. And Dr. Abraham, would you be able to, since we started 5 minutes late, would you be able to stay just 5 minutes extra?
Oh,
in case
sure.
anyone
I didn't want to
has-
infringe
And
on
obvious,
everyone's time.
yes, exactly.
Okay.
Yeah, exactly. So obviously we understand if people need to hop off, but if you're have questions and are able to just stay for 5 extra minutes, it sounds like we could do that. But we do have a question that came in. Since you're a faculty member based at Anschutz, how will you get to know students, faculty, and staff at UNC and CSU? And how will the 3-campus structure of our school influence your approach as an administrative leader?
Yeah, great question. I hope that I can build very strong relationships across the campuses. I've been teaching, so, I already engaged with some of the instructors around curriculum, certainly around epidemiology curriculum. So, I think it's all about trying to build relationships. And I, really want us to sort of make this tri-campus model successful in terms of driving forward better education, better partnerships, sort of harnessing what is, a very nice model to do wonderful things. So that's sort of the short answer. I'm not sure if you were looking for something more in depth and detailed. I'll pause there and see if you want to unmute or sort of ask something more as a corollary.
I'm not getting a follow-up question, so
Okay.
if anyone else has any questions, please put them in the Q&A and I'm happy to read them.
While others are queuing up questions, Allie, I'll just ask you, Danny frequently gets a number of new program proposals, because that's how the incentives currently work for departments to be able to do. How would you evaluate them? What would be a process? Well, I loved your presentation on curriculum reform and how to go about that. How would you decide which programs to sunset and then new programs that are that just constantly come in? How do you evaluate that?
Yeah, I think that's very tricky. Obviously, if people are putting in proposals for new programs that they feel that they see a need and that there's merit in that program. But I think, programs that we implement need to be consistent with sort of our mission and direction that we've all come together to agree upon. So, that's the first thing is this going to sort of, further where we want to go? And part of that is about sort of the identity that we develop, what are the sort of areas of emphasis. You can't invest in every single idea and do it all well. So, we need sort of a targeted approach. So the first thing would just be, making sure that those programs are sort of consistent with where we have all come together to agree that we want the new school to, or the new, we're not that new, we want the school to go in any, new curriculum that we develop. Then I think, the process sort of can't be, just me. There has to be sort of consensus. So, I think that we would definitely want to have input in some form from various constituencies, students, staff that would have to sort of be a part of implementing any new programs, and obviously faculty that would be involved in teaching those. What is the feasibility of this? Does it really sort of improve education? So I would advocate sort of not just a top-down approach, but, sort of a community approach to trying to figure out what programs are in the best interest. And again, I think sometimes we're going to disappoint people by not making all programs that are proposed a reality, but hopefully we all sort of focused on the idea that, again, you can't do everything well. We really have to focus on, a couple things and do those things really well. So, hopefully just getting buy-in that, that's all of our goal.
Thank you.
Thanks. We have a couple of other questions. We have 2 more minutes. So what are your thoughts and ideas surrounding increasing diversity among our student body and increasing equity and inclusivity on our campuses and in our classrooms?
Yeah, well, you have heard my big pitch for being more inclusive. I think we should broaden out the educational mission. So I really do think that we should start reaching into communities and thinking about, how we offer educational content. Can we do a better job of offering it in ways that's more palatable, whatever sort of descriptive word you want to use there, to varying diverse constituencies. And I also think that we have to think about diversity along a lot of different axes. So, we tend to think a lot about populations who are, historically minoritized, but, there's also a lack of older students here. There's potentially a lack of individuals who sort of represent the community of people living with disabilities. So there's a lot of different axes of diversity that we can think about. And again, once we decide to sort of be diverse and we have to make sure we're inclusive, right? So diversity isn't enough. We have to make sure that we've modified our practices and our curriculum in order to make sure that those people are truly included.
Well, thank you. I think our time is up, but thank you very much for your presentation. And I'm sorry we weren't able to get to every question, but.
All right. Thank you so much, everyone. I appreciated the questions and your time.